This video wraps up Chapter 17 of OEC 6, looking at obstetric emergencies. And in this case, we'll talk about normal childbirth along with management of a patient in the legal situation where perhaps a sexual assault has occurred. So we see these objectives listed right here. Also, after delivery of the woman during normal childbirth, we'll describe basic care for the newborn. So this is our list of key terms from Chapter 17, and let's take a look at management of these patients. So you may encounter a patient who has vaginal bleeding, and this is associated with the emergencies described previously, such as an ectopic pregnancy or placenta previa. So in this case, we always want to use an external pad to absorb the blood, and keep in mind that this patient may lose 30 to 35% of their blood volume before showing signs of shock. The woman's vital signs may appear stable because she's compensating very well, but the second patient, the fetus, will be in shock due to the fact that the mother's body is shunting blood to her system, therefore decreasing blood flow from the uterus to the placenta and therefore to the fetus. So anticipate the development of shock in a pregnant trauma patient and her fetus, even if the vital signs are normal because of her compensation. Provide oxygen and transport using ALS. Now, in the case of delivery, we may encounter postpartum bleeding, and that hemorrhage can be in excess of 500 mils. So we can do a couple of things. Make sure the woman is on her left side, and this will prevent any lowered blood pressure due to pressure on the vena cava. And massage of the lower abdomen can stimulate the release of oxytocin, which causes the uterus to contract, and that muscle contraction can help resolve some of this bleeding. If you have to transport a trauma patient and spinal motion restriction is one of your considerations, of course, don't place any straps directly over the patient's abdomen, and consider what we've seen before with hypotension in a pregnant patient. So go ahead and rotate the backboard a little bit by tilting it about 4 to 6 inches. Maybe put a blanket or a quick splint under the right side of the backboard when it's in a toboggan. And that's also going to help with the other possibilities, such as keeping the patient's airway clear should she vomit. Now, in a normal childbirth, during the first stage of labor, we'll see recurring contractions at 3 to 4 minute intervals. They'll last for about a minute. Dilation of the cervix occurs in anticipation of the delivery, and along with those contractions, there's going to be lower back pain. In the second stage of labor, the fetus is starting to descend through the birth canal and the baby's delivered. After delivery of the baby, we have to concern ourselves with delivery of the placenta. So signs of an imminent delivery will be rupture of the amniotic sac, which is typically the clear fluid that's encased there, the amniotic fluid. Occasionally, it's going to have some coloration just due to stool from the fetus being part of that fluid. In the emergent case of a prolapsed umbilical cord, that is, the umbilical cord is actually visible at the vaginal opening. It's in front of the fetus's head. We need to instruct the woman to stop pushing and transfer her to higher care and provide her with supplemental oxygen, because we can actually have compression of the umbilical cord, and that's potentially dangerous for the fetus. If there is imminent delivery possible, we may be required to assist with that. So we can time the woman's contractions from the start to the next. During that occurring, we can note the duration of a single contraction by recording time of onset and its completion. And if we see the baby crowning, we know that delivery is imminent. We can prepare to assist with that. This is described in the skill guide in Chapter 17. Now, after birth, we want to just recognize that some vaginal bleeding may occur. Typically will end after the placenta has been delivered. And as stated previously, massage of the lower abdomen can allow oxytocin to be released, and that will trigger contraction of the uterine walls, and that can help stop some of this blood flow. The mother, the baby, and the placenta should all be transported to the hospital. Now, if there's excessive bleeding, we're essentially going to be treating for shock. The mother will stay in the supine position, will provide supplemental oxygen, and monitor vital signs. We can use dressings, in this case sanitary napkins, outside the vagina and the perineal area. Considering the newborn, once the infant is delivered, we can vigorously dry it off. This will typically stimulate the newborn to begin breathing on its own. We always would just consider assessment of the newborn, beginning with the ABCDs, looking for airway and breathing. We'll suction the baby after the head is delivered and again after the baby has been completely delivered, but we do this with one of those infant bulb syringes. Usually the infant is going to begin crying, often while being dried off because of that stimulation. If they don't begin crying, which is a sign that their airway and breathing are typically normal, we can just provide just a finger flick on the soles of the infant's foot, and that should stimulate that. If they don't begin to breathe after 10 to 15 seconds, then we need to breathe for this newborn patient. If the patient appears to be breathing well, then we would move on to the C part of our assessment. We'll assess the pulse, and remember, for children and newborns, that's brachial. Because of their small body size, their pulse rate should be pretty high, between 90 and 180 beats per minute. If it's less than that, a lot of times it's associated with the respirations of the infant, and so we want to begin using a BVM with an infant-sized mask placed over the baby's nose and mouth, and we're breathing for them at 40 to 60 breaths per minute. We use just enough pressure, as we always do with the BVM, to observe chest rise, being careful not to overinflate the lungs. After 90 seconds, we can reassess the pulse rate. If it's less than 60 beats per minute, we can give oxygen at low concentrations and increase that slowly until we achieve that infant heart rate of about 100 beats per minute. Assisted ventilation with the BVM is the most effective action that we can take. An infant's skin color is another good indicator of its well-being. We include this, for example, with all children in our pediatric assessment triangle. So lack of oxygen, hypoxia in the infant's bloodstream is going to cause cyanosis of their face. And this can happen for up to several minutes after delivery as the infant's own hemoglobin passes through the lungs and begins to become saturated with oxygen. This can take up to 10 minutes for that full circulation to occur. Newer evidence has shown that the clinical assessment of skin color is a poor indicator of their oxygen saturation immediately after birth. If the infant has strong regular respirations, we can consider using blow-by oxygen just to increase the amount of oxygen near where they're respiring, close to their nostrils, and this can support them. Once again, if the newborn is not breathing, we begin ventilation with a BVM and then slowly increase the oxygen percentage as needed. Now we move to chest compressions or CPR for the infant if the pulse rate is lower than 60 beats per minute. Pulse rate between 60 and 100 beats per minute, despite adequate ventilation with supplementary oxygen, also requires CPR. Even though the infant may have pulse that we detect brachially, the slow heart rate and the cardiac output are just inadequate for this newborn. So remember, ideally in two-person CPR for a newborn, we're going to encircle the chest using our thumbs over the sternum as our current standard indicates, and we'll continue that CPR along with the ventilations through BVM until we get that heart rate greater than 60 beats per minute. Remember, infants are pretty resilient and they can survive prolonged effective CPR. If the baby's doing well, put the baby in an improvised crib so that it is safe. And that could be a basket or a cardboard box that you pad with blankets, and this will help also to keep the baby warm. Neonatal hypothermia is reported in half of all pre-hospital deliveries. Finally, we could actually assess using the Apgar score, and so we can consider the appearance and that skin color indicating that we've got good oxygenation. The pulse is something we've previously assessed, and we get this responsiveness in an infant. That's going to be grimace. We'll also get some activity, and we can assess respirations by how strongly they're crying. The Apgar score is helpful in determining if the baby's doing well on its own. If the infant needs resuscitation before the 1 minute score, don't wait. If the 5 minute score is less than 7 on the Apgar score, just keep obtaining scores every 5 minutes for 20 minutes. Now we wrap up Chapter 17 by discussing a patient who may have been the victim of a sexual assault. That is physical contact of a sexual nature without consent. The perpetrator may be of either sex, but is typically male, and is typically someone known to the victim. This is a legal instance, and so we have to consider the physical trauma that may have occurred and the psychological trauma that may have occurred. Victims of sexual assault can suffer from anxiety or eating disorders or depression as a result of this incident. So in most states, you are a mandatory reporter in regards to sexual assault, and you have to report to law enforcement officials. This is a serious problem. It's a legal problem. So we can respond very carefully by reassuring the patient and dealing with their medical needs. In this case, if there's bleeding, we want to control it, but we want to do so in a dignified manner, and we want to make sure that we leave the exam of the victim to higher level medical personnel, and that may be subsequent to transport. Remember, we need to report to law enforcement immediately. Our bedside manner, in terms of being careful and compassionate and respectful, is critical. We need to make sure that we provide them with privacy and ensure confidentiality. This might require us to minimize the number of people around the patient, and if possible, for the assessment and even treatment of this patient, if a female patroller is available, let's be sure to use that resource.